I just wanted us to briefly go through what we'll be discussing over the next week, and maybe some part of next 2 weeks. Basically, we've done all these things before. And that's why I gave you the initial option that we can just write medicine 2 exams, and then a new lecturer will come in and then take you through a sort of a revision of what we did in medicine 1 and 2. We'll do a revision of the emergency aspects in level 400 if you want, and then afterwards you can write like an exam which will be a 2 credits 2 credits course exam on that. But I think we all agreed that, I mean, because we've actually done all these things, if you look at them, we've done all these things. We basically go to as a revision and then possibly write exams on that, so that in level 400 you can have time. You wouldn't have to worry about anything medicine, both in internal medicine and emergency medicine, which has always been the headache for students in level 400. You can have time and concentrate on other things and have the practical session done. So these are the topics. Basically, we are done with the internal medicine to just 1 or 2 topics. If you look at the topics I sent you, the only thing left that we didn't really touch on was the leukemia aspect, which we can just find a day and go through. I'm not going to give you an exam question on that. I don't think MDC will also give you a question on that. They usually like common things, common cases, but it's okay if you know them. So we can always find time, maybe an hour, to go through acute leukemias and chronic leukemias. But I've given you slides, so you can also try and read through this, basically straight to the point. So when there's time, we'll go through. So basically, that will bring us to an end with the topics in your booklets that we are supposed to do for internal medicine 1 and 2. Out of that, I try to get topics for emergency medicine because they didn't give any. They just want us to have a course and prepare you for your emergency medicine clerkship input. Clerkship means that you go to the ward and you do all you're supposed to do. Ideally, we expect that you use the knowledge learned in internal medicine because we taught you most of these topics there, and you apply when you go and do your emergency medicine clerkship. But I usually like to take students through more of a revision. By this time, we will be touching on the emergency aspect of the topics. And basically, the focus will be on management. So for instance, in internal medicine 1, we talked about asthma. So we went through all those things, the types and everything. And we talked about management as well. But when it comes to emergency medicine, our focus will just be on the management. Because once the patient comes to you, that is what your focus is on. You want to stabilize and manage your patient. So once we start doing the revision and we are talking about asthma, we are not going to go back and talk about all those things that we talked about. We'll just go straight to the management. Your colleagues in 400, I think we did this not so long ago, I think a month or 2 ago, and we recorded some WhatsApp. I did some videos on Zoom for them. So I'll try and see the ones that are still available on my laptop. I'll send it to Nick, and then Nick, you can upload it on your YouTube page so that, you get what we'll be talking about here, and then you can always go back there and also get what we talked about previously. There are always new things to learn. So basically, that's how we'll be doing the emergency medicine. Something like COVID-19, I gave you a lecture on that last semester. I gave you slides. This time around, we'll be talking about the management of COVID-19. So that will just take us about 15 minutes. And it's like things that you're supposed to know and you're supposed to memorize. When you are sleeping, we'll wake you up and we tell you there's a patient with COVID-19. What are the things that you need to do for the patient? That's what emergency medicine is about. So we did pneumonia in medicine 1. We are going to now just do a review of the pneumonia management. Basically, you admit, you check SpO2. I mean, all the basic things that we'll do will be practical as much as possible. Okay, so that's what we are going to do. So, I mean, even if we have 1 hour, we can actually do about 2 or 3 topics. So with this revision, we can even be done in a week, basically. For instance, I think I took you through DKA not so long ago. So we are just going to do like a quick revision of that, and then the management. Basically, that's what this is about. So I'll send this to your platforms that you can be reading around it. Your exams will basically be around this. Okay, you are going to get 3 questions on these topics here. I mean, 3 easy. The exams will be due. We would probably bring the topics down to probably 5 to 7, which you get 3 out of them. And then you get 50 MCQ questions to solve. Usually you get 5 questions on emergency medicine, but I do understand that you have a very short and a limited time to prepare. So we are going to do 3 questions, 3 straightforward, simple questions this time around, and then 50 simple objectives this time around, so that everybody will be okay. Right. So we'll talk about atrial fibrillation. We'll talk about, I mean, management of atrial fibrillation is just a revision because we've done this. Management of cardiac arrest, management of acute LVF, management of acute coronary syndromes, management of pulmonary embolism, management of COVID-19, asthma, pneumonia, respiratory failure, how you manage your pulmonary edemas, epilepsy. We recently had a PowerPoint on it, so I think that'll be straightforward. Strokes, look at the management for strokes. That's hemorrhagic stroke and infarctive stroke. As a matter of fact, I'm going to give you an exam on that. So as it stands now, out of your 3 possible 3 questions that will come, you know that you are going to get a question on stroke. You are going to get a question on something that looks like malaria, sepsis, intravascular hemolysis, which would require that you bring your mind to play and then make a diagnosis. That question wouldn't expect you to make the straightforward diagnosis, but it will expect you to make differential diagnosis based on the case and then how you go about making the correct diagnosis. So if you take every differential, I expect that you tell me that with this differential, you need to rule out this, and then you need to do this investigation. And with that differential, you need to do this and you need to do this. And then how you would manage any of the differential diagnosis that you are looking at. So you get a question on that. So that's 2 questions. So now it means you have 1 more topic, which I'm sure by the time our exam is getting closer, you have an idea. It can come from maybe you can get it's common. You can get a question on acute kidney injury, which is also common. I can give you a question on pulmonary embolism, which is also common. And I can give you a question on DKA. So these 4 topics are very common areas, which I already have questions on. So you can get a question on pulmonary embolism, DKA, acute kidney injury, or sickle cell crisis. That could be your 3rd question in addition to your question on stroke and intravascular hemolysis, secondary to maybe some sepsis or malaria or something. You get those questions. So it's quite straightforward, right? I don't want anyone to struggle during this exam. Okay, so I'll send this to your group pages, and the main reason why I'm sending this it's not for you to keep it as an artifact, because we'll just be going straight to management. I expect that before the lectures, you would have read, this is just a revision, you've read and written exams on it before, so you would have read before coming, and then it will make things easier for us. So for instance, tomorrow we are going to talk about management of 1, 2, 3, and 4. So tomorrow our focus is going to be on the cardiac aspect. We are going to be looking at atrial fibrillation, cardiac arrest, acute left ventricular failure, and acute coronary syndrome. So we'll spend about 15 to 20 minutes on how to go straight to boot management for these 4 things. So try and then go through, you already have the slides, so try and go through before you come tomorrow. Then hopefully, I'm hoping to be able to get an hour of your time within next week. So from Monday to, we can do 5 out of 7 days, so that we can have 2 days to rest. So each of the 5 days, we can do, for the days for Wednesday and Friday, which are in quotes mine days, when we meet, we can go beyond that 1 hour. So we can end up discussing about 3 to 4 topics. But then the other days, like on Monday when we meet, we are just going to go straight to management of pulmonary embolism and COVID-19. It shouldn't take us more than an hour. We will finish. Even in 45 minutes, we can finish. That's if you've read before coming. Then on Tuesday, we can do same for management of asthma and pneumonia, which we can actually cover in less than an hour. Wednesday, we'll be looking at 9, 10. We can touch on epilepsy and stroke. But I mean, there's something that we've done, but of course, we'll still touch on that again. Then on Thursday, we'll just look at DKA management and HHS management, which, because Thursdays are not my days. And then on Friday, we can look at the thyroid ones. So 15, 16, and the management of sickle cell. Then on Saturday, we can also look at what is down here, and then we are done. Okay, so it's quite straightforward. With 19 and 20, it will be an interactive session. By Monday, we'll know how we are going to go about it. I would like the regular students to give us a PowerPoint presentation on shock. I like the weekend students to also give us a PowerPoint presentation on poisoning, which we'll discuss next week, Saturday, hopefully. Are we okay with that?
Yeah, sure, Doc.
Yes, sir.
Okay. Okay. So
Hello,
your exam, yes, please. Hi. Hello. Yes, hi.
Yeah, sir, I learned you are writing the exams on pages. I mean,
Yes. Yes, so I was coming to that. So your exams was ideally supposed to be next week, Friday, but then due to 1 or 2, it was shifted to next week, Thursday, which was going to be the 26th. But I'm hearing there are other things involving other members of the class as well. So we are planning, and after the class, I would let your class reps discuss with you. We would have to move the exams to the next week. But because we are also preparing for a supplementary exam that same week, okay, we are preparing for a supplementary exam that same week on Friday, which will be the 3rd, because we have to give other people the opportunity to write so that they can also have marks there to fill. Because we are preparing for that supplementary exam, we can't put the internal medicine 2 exam close to the weekend. So we might have to write it on either the 30th, which is Monday, or 31st, which is Tuesday. So it's something that you would have to discuss as a class, and then let me know what you want to do. If you also think about it and you think you can't write the emergency medicine exam because it's too soon, you want to write it in 400. I mean, I'm also fine with that. We can just write the internal medicine 2 exam on Friday, which will be the 3rd of September, and then we do the supplementary the following week, which will be the 10th. That will mean that will be it. And then in 400, the new lecturer will take you to do your emergency medicine and then have an exam for you. That's why we are having this session this evening, so that you can discuss and then know if you want us to proceed and have exams, emergency medicine exam on the 10th, then we will go ahead. That will mean that you would have to write your internal medicine and will be pushed forward to either the 30th or 31st of August to make way for supplementary on the 3rd. Any questions, please? Hi.
So, I want to ask a question pertaining the topics.
Yes, please.
Is it possible to get exams on a topic here as an emergency and still come in the internal medicine too?
Oh, I've virtually given you the topics you'll be getting in emergency medicine exam, and I'll repeat those one in internal medicine too.
Yeah.
Emergency medicine, I'm going to give you 3 questions. And already I've told you to be focusing on stroke, and I've also told you to be focusing on something related to intravascular hemolysis. As you talked about, you gave the presentation on malaria. I said I'll give you a question related to that. So you should be focusing on complications of malaria and sepsis and all those things, because you get a question on that. I'm saying the 3rd question would either come from a pulmonary embolism, a topic relating to pulmonary embolism, or acute kidney injury, or DKA, or sickle cell diseases crisis. So I've out of 20 topics, I've pointed you to 2, and the other one I've given you 4 options. Even if you get just the 2 correct, that is like more than 50% you've passed. Okay. Your exams on internal medicine 2. The topics are a lot, but as I promised, you can't study everything in this short time for the exam. So there would always be study areas. You are going to get, ideally, you're supposed to get 5 questions, 20 marks for each, which will make it 100. Okay, and then you're going to get 100 MCQs, just like internal medicine 1. However, yesterday, I think when I slept, an angel of God appeared to me that we are not in normal times.
Thank God.
Not in normal times, and the fact that even during your revision next week, you'll be having classes one way or the other. It won't be so fair to give you 5 strong questions. So we are going to have 3 questions, 3 easy questions. Okay, 3 easy, straightforward questions. I usually like giving questions on CNS, and my favorite question will be on stroke. But as I said, the stroke is going to appear in your emergency medicine, so you won't get it. You get a question on respiratory system. I promised you guys last semester that I'm going to teach you COVID. And even if you don't get a question on COVID now, you are going to get a question on COVID before we are done. So expect a question on COVID for internal medicine too. That will basically isolate the respiratory aspect of things. You are going to get a question on the renal system. It is possible not get a question of the possible topics you should be seeing in question 3. It's also possible you won't get it. In case you are not getting it, you are going to get a question on renal. And renal, like I taught you acute renal failure, chronic kidney injury, nephrotic syndrome, UTI. You are going to get one question from there. Okay, so you should really learn your renal things well. That will be your second question. I like infectious diseases so much. And that is why I took my time in teaching HIV/AIDS. And just like last semester, the way I took my time in teaching viral hepatitis and whatnot. I think I've also taught you meningitis. And I also taught you enteric fever. You'll get a question on infectious diseases. Okay, it's possible you get a question on HIV/AIDS, meningitis, or enteric fever. All right, so that would be the third. So internal medicine 2, they are focusing on renal, which you can get a question on any of the 5 easy topics I taught. I'm going to get a question on infectious diseases, HIV/AIDS, enteric fever, or meningitis can actually pop up. Okay, and then you are also going to get a question on COVID. So for your exams, your internal medicine 2 exams that is coming up, kindly focus on these areas. You get 100 MCQ questions, which will cut across all the systems. So that one, every system will come. You get a question on rheumatology, SLE, and rheumatoid arthritis. You get a question on hematology, anemia, and all those things. You're going to get a question on endocrinology, diabetes, and all those things. 100 MCQ questions, that will come. Any questions with that, please?
Okay.
Yes, hi.
Some of the infectious disease that we did last and I think some of them appear in the objectives. So this time we are bringing them up in the
class low.
Yeah, so yes, you might see some in your MCQs. And as I said, I mentioned meningitis and enteric fever and whatnot. I've already taught you that in internal medicine 1. But don't be so surprised if you see it as your question 3. Or maybe you can see HIV/AIDS there because we just did that. So if you are focusing on infectious diseases, there are so many infectious diseases, but I've brought you guys down to meningitis, HIV/AIDS, and enteric fever. So kindly take a look at it. Okay. Are we okay?
Yes, sir.
When you are marking and the correct a lot, it's easy to calculate, you see, because you put the marks there, diagnosis. No, like diagnosis, 2 marks, investigations, 4 marks. So it's there. So if you are just writing, and then it's easy to calculate. So you just put it there, 18/20, 20/20. But if you are getting a lot of wrongs, then it makes it difficult. Then now you have to think. Ideally, the person is supposed to get 0 for pathophysiology, but you know that it's not fair because at least he has put ink on the paper. So you are thinking, should I give 1 or 2? Then you are in between. But meanwhile, the person is actually supposed to get, oh no, I can't give you simple questions like that. You won't be seeing simple cases, you see. And that is one of the things that in as much as I am sad that people would have to resit the internal medicine one, trust me, I'm not so happy, but I had to do it because if I don't do that, God won't forgive me for any life that is lost because of someone's incompetency, which I could have prevented by just allowing the person to read just a little bit more. You see. Honestly, I wanted everybody to pass, but then I had a counsel with a wise woman, and then she told me that the receipts won't be so bad for just a few who didn't, so that at least they can take care of people who would fall sick. So that is the reason why I had to let people resit. I'm sorry if you have to resit, but trust me, it's for the better. And everybody who is resitting would pass. Just put in the effort. Okay.
Doc,
Next
you've done
week
your
I'll
best.
have a So next week I'll have a session with all those that will be resitting after the internal medicine 2 exam. So you'd also have straightforward areas to learn. It's also going to be 3 questions, but then it will be 50 MCQs and it'll be straightforward. Okay, so don't worry about that, you pass. All right, so before we close, let's take a look at this. I just want to see how prepared you are for this emergency medicine session we'll be having. As in, I know we've already had, can you see my screen?
Yes, sir.
Yeah, I know we've already had sessions, but I just want to see if you remember. So let's quickly go through these few things, and then we can close. Okay. So, question 1. All the following are features of heart failure on the chest X-ray, except anyone at all can answer, and then if there's an explanation, just give us a brief explanation of heart failure on the chest X-ray, except A is cardiomegaly.
Sir, Hampton sign.
The D.
Okay, the D. Why? Why is it a D?
So you give during the presentation A, B, C, D.
Okay. So you
Yes,
remember
so-
with that?
Yes, sir.
Okay, but where do you find the Hampton sign?
That's pulmonary embolism.
Good, excellent, good. All right, people remember. Okay, good. So a 42-year-old man is rushed to the ER with severe chest pains. Which of the following is not a differential diagnosis?
Sir,
So
acute
Acute cholecystitis. Okay, why? Why is acute cholecystitis?
Inflammation of the bladder. It doesn't have anything to do with the chest.
Cholecystitis, the pace will be at the right upper quadrant, not at the
quadrant.
yeah.
Good, excellent. So right upper quadrant of the abdomen. That's good.
Yeah.
Okay. So this drug is used in the active management of atrial fibrillation for its antidysrhythmic properties. What drug is that?
It
So,
goes,
A.
it goes in.
Digoxin.
Yes.
Digoxin.
The A.
Okay, yeah, right. Okay, so this emergency medicine revision is actually going to be easy. Clinical features of acute left ventricular failure include the following, except clinical features of acute left ventricular failure include the following, except. Just relax and take a look at it. The answer is there.
Raise JVP.
Raise JVP.
Yes.
Okay. Why raise JVP?
left.
So the thing, the raised jugular, this thing is supposed to be right.
Okay, good, good. That's excellent. Okay. So which of the following is not a clinical feature of meningitis?
The B.
The B. Okay. Where do you find B?
Is it
TB,
positive?
TB.
When you
Tetanus.
have a BA,
Number
let's see.
What is Babinski sign? I taught you not so long ago, just a couple of days ago.
Yeah,
No. Which of the following is not a clinical feature of meningitis?
Yeah, right. The answer is B. But what is Babinski sign?
What is what?
Doc, is the
sir,
bending
is
of
that
the
about
toe.
the plantar flexing and
The
the
bending of the toe.
dorsal flexing?
Okay, so yeah, it has something to do with plantar flexing. Where do you find that? When do we say Babinski sign is positive?
The one you have a peptic
What-
ulcer.
Yeah, when the big
No.
toe bend, when the big toe bends towards the foot.
When you have a upper motor neuron defect,
Yes, when you have an upper motor neuron lesion. Remember when I taught you stroke? I said that's one of the things you find. So kindly look at your stroke slides since you'll be getting a question on stroke. When you have an upper motor neuron lesion like a stroke, and we try to test for Babinski sign, which I expect that you all watch a YouTube video right after this lecture to know what it is, because you have to elicit it. You need to elicit it in clinical practice when you are on the ward and you see a case of stroke. Okay, so I expect that you all take a look at it on YouTube. So Babinski sign will be positive when there's an upper motor neuron lesion, because when you try to test for it, the toes would move what? Up. All right. So we say that it is what? Up. And it would fan out. And we say Babinski sign is positive, means that there's an upper motor neuron lesion. Okay. Good. A pneumothorax refers to, what is a pneumothorax?
It's
A.
it's collection of air in the pleural cavity.
Good.
Hey,
Okay. A. The severity of pneumonia is determined by all the following except.
There is C. Systolic blood pressure greater than 140.
yeah, see.
Good. Good. It means you remember your KEP 65 score. That's excellent.
Yes.
Clinical features of acute coronary syndrome include the following, except. Clinical features of acute coronary syndrome includes the following, except.
I think B.
Why B?
is E.
Loss of consciousness.
When you get an acute coronary syndrome, you can end up collapsing.
Okay. Is A is
B.
A.
Who said A? Someone said A. Why is it A?
Because acute coronary syndrome does not respond to GTN.
Good. Excellent. You remember. I like that. Like that. So acute ST elevated myocardial infarction, non-ST elevated myocardial infarction, and unstable angina. And usually, if you give your GTN, it won't resolve, unlike your stable angina, which will just resolve when you give your GTN. Are we good?
Yes, sir.
Okay, good. Which of the following enzymes is highly sensitive and selective in acute myocardial infarction?
Hey,
Troponins.
Troponins. Good. I like that. a sudden transient loss of vision in one eye, which is a feature of TIA, is known as what? It's in your stroke slide.
B.
What's B?
It's
Okay,
B.
good.
It's B.
B. Okay, that's good. The answer is correct. Investigations. Oh, it's straightforward though. This one, I'm not trying to
It should be
confuse you.
E. The E.
Yes, it's E. It's E. Why do we do a carotid artery Doppler?
There may be a clot in the carotid.
A clot, okay, but I'll prefer you use another word than a clot. Could be a plaque or a plague. A plaque, like atherosclerosis in the carotid artery, which would reduce the perfusion to the brain. Because as you know, the carotid artery is what will go up, branch into internal carotid, forms the vertebral artery, blah, 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 goes all the way up, all those things, and then supplies the brain. So if you have a very huge plaque sitting in the carotid, then you are going to have some form of defect in blood supply to parts of the brain. And so when you do your carotid artery Doppler, it will show you, okay? Okay, active management of intracranial hemorrhage includes the following except.
C.
Okay. Why? Why is it C?
If you do coagulant therapy, the person will bleed more.
Okay, that's true. Which of the following medications will be most preferred in the treatment of subarachnoid hemorrhage?
C.
Nimodipine. Okay, that's true. All the following are used in the active management of seizures, except.
Say A.
A.
Yes.
Propranolol. What is propranolol?
I think beta
Okay.
blockers.
It's a beta blocker, so antihypertensive, and then also for anxiety. Okay. This is not a clinical feature of diabetic ketoacidosis.
D.
D. Did I hear B or D?
D.
D. Okay, good. What is D? And where do you find D? In what condition would you usually find D?
Complicated hepatitis.
So chronic liver disease. Chronic liver disease. Okay, use that one instead. Okay. Active management of adult hypoglycemia involves the infusion of, what's the answer?
A.
Okay. Okay, so don't ever forget this. If you are asleep and they even wake you up, you should be able to select. Funny enough, in exams, you find people settling D for this question, and then you are so sad because even if in the end the person has gotten 40/50, you are worried that if a patient comes in with hypoglycemia, they'll go and give the patient insulin on top. So please, let's be careful. Okay. So myxedema coma is a complication of hypothyroidism. It presents with
Hypothermia.
hypothermia. Good, excellent. People are reading the slides. Management of thyroid storm involves the use of all the following except sometimes some of my questions, it doesn't even matter if you've read the slide or not. If you just apply some small common sense around, you get the answer. That is if you know what we are talking about. Of thyroid storm would involve the use of all the following except. What is a thyroid storm? What's the thyroid storm?
Excessive release of somebody who has thyroid.
Okay, so in thyroid storm, what is usually going up in excess? Thyroid hormones, right?
Okay.
So in the management of a thyroid storm, amongst all these things, what wouldn't you want to give the patient?
Levothyroxine.
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 You won't want to give your patient levothyroxine.
You give
exactly, you rather give something to lower the thyroid hormones, but you won't give something that would rather increase the thyroid hormones. Levothyroxine is given in hypothyroid cases. So if a patient's thyroid hormone is low, then you want to give levothyroxine. However, if the thyroid hormone is excessively high, you want to give anti-thyroid hormones like propylthiouracil, and then you want to give something calm down the pulse, and that's where propranolol comes in. So don't get this wrong if you see it anywhere. Okay. Stage 5 of the RIFLE criteria in the assessment of acute renal failure is persistent renal failure for more than 3 months. Good. A 39-year-old man develops severe shortness of breath, wheeze, and widespread urticaria, affecting the face and the skin of the trunk after a seafood meal at a Chinese restaurant. This reaction occurs as a result of mediator release from which of the following type of cells?
Mast cells.
Mast cells. Excellent. The following are types of cardiac arrest except
E. Atrial flutter.
Okay.
Yes, sir.
All right. Atrial flutter. So if you remember cardiac arrest, you have what? Ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, and then what? Asystole. You remember, right?
Yes.
Okay. The following are causes of type 1 respiratory failure, except mind you, type 1 respiratory failure is respiratory failure, which is directly due to the lung problem, and type 2 is sort of secondary to something else, which is causing the respiratory failure. So what is your answer?
Then B.
Guillain-Barré. Good.
Yes.
Guillain-Barré. This drug is used in the management of aspiration pneumonia.
Metronidazole.
Okay, that's good. The use of this drug in the management of COVID-19 may lead to hyperglycemia. Dexamethasone. Why?
It can release into the blood.
Okay. So it's a steroid.
The steroid.
Okay, and the side effect of steroid is increased blood sugar. Okay, good. Current drug of choice for the initial management of severe malaria. What is it?
Artesunate.
Artesunate. Good. Artesunate. A patient with ascites, caput medusae, and parotid enlargement presenting with massive hematemesis is likely to have, I taught you this last semester.
Hey.
B. Okay, sure. B. It looks like there's some dog trying to choose someone. Please check on your platform.
Yeah, that is me.
The dog wants to choose. The dog wants to choose the question.
Your landlord's dog will chew you.
How will hemorrhagic CVA appear on the head CT scan?
Hypodense.
I taught you this once a few days ago.
Yes, CV.
And then I showed you slides and I said, if there's bleeding, it will look white. If there's an infarct, it will look black.
Hyperdense.
Good.
Bleeding
Hyperdense.
is hyper.
So hyperdense. Okay. When would you use the term hyperintense? When do you use that term?
Black is true.
When the black is very deep.
Try again. So just like the way when you are trying to explain or write results for X-ray, you say what? Radio opaque or radio lucent. And then ultrasound, you say what? Hyperechoic and hypoechoic. And CT scan, you say hyperdense or hypodense. MRI scan, you say what?
Hyperintense.
Good. Okay. All right. Babinski sign has popped up again. Another name for Babinski sign is flexor plantar reflex. So flexor plantar reflex is a feature of all the following except
Poliomyelitis. Polio.
Why polio?
Looking at the,
I mean,
the CV,
no, so I mean, the test that is done, that Babinski test can either be a flexor or an extensor plantar reflex, and it means different things. And remember, I taught you guys that when you say that it has flexed, then it means it's going down, and it would usually represent what? An upper motor neuron lesion. And when it extends, then it means it's gone up. Your toes have extended, they are moving up. So it will represent what? An upper motor neuron lesion. So if you have a flexor plantar reflex, it would involve all the following features here, except what? Oh, it's straightforward. Which one is the odd one out? Which one is the odd one out here?
The polio.
Oh, how? Why is polio the odd one out?
Because looking at the TV for the first one, well, it has an effect on the plantar flex. And then CVA in the DM.
You know, CVA, when we were talking about the CVA, we used Babinski. We didn't specifically say flexor plantar reflex. We said Babinski. Okay. So if you look here, flexor means that, and remember what I told you, I said that upper motor neuron lesions would go up. And when it goes up, it's what? An extensor plantar reflex that's extended. And stroke is an upper motor neuron lesion. So when you try to do a Babinski reflex, you are going to have an extensor plantar reflex.
Okay.
Do you get it?
Yes, sir.
Guillain-Barré, peripheral neuritis in DM, motor neuron disease, poliomyelitis, all these are lower motor neuron lesions.
Okay.
Right?
Yes, sir.
Because the problem is after the nucleus of the nerve, whereas upper motor neuron lesion means that it is what? Above the nucleus. Good. Okay. So that's the old one out, CV. A stereotype perception caused by initial focal electrical activity before a seizure is known as what?
Aura.
Aura.
Aura. Okay, good. Aura. How long should you continuously have a seizure without breaking, without recovery, for us to say you have a status epilepticus?
5 minutes.
5 minutes. Good. Okay. So I can see that our revision wouldn't be so difficult, because these are basically questions that will be popping up in our revision. And you don't even need to have a revision at all for the emergency medicine, because I can see we are ready. But we'll have it anyways. So just try and go through your slides. You won't get difficult questions. You get questions similar to what we just went through. Like it will be very, very similar to what we just went through. Straightforward questions on management of emergency conditions. Okay. So you see all that we talked about falls under these topics that we'll be going through from tomorrow, right? So try and go through the slides. Try and use these questions that we've gone through to revise, to remind yourself of how the questions will look like. Come 2 to 3 weeks time, you have 50 questions like this, and then 3 questions, topic areas that we've already discussed. Okay, so pay attention to your stroke and your how do you call it? Your IVH, and then the other topics that I've given you. Okay, for that, and then internal medicine. That's what we are writing first. So pay attention to your COVID. Pay attention to all the other 2 that in your renal. Definitely, you have a question coming from there, and then
infectious disease.
Yeah, you have a question coming from there as well. Infectious disease. It's common because we are in an environment full of infections. And just focus on the very common infection which we are worried about, and read around it. Read around all the clinical features it comes with and the organisms that causes the clinical features, because I'll ask you a question on that. If let's say I give you a question on HIV/AIDS, I can ask you a question on a presentation based on the case study that I've given you. What kind of organisms are causing this man's or this woman's plight? And what condition are they causing? I can give you a question on that. And then I'll ask you to manage. And if I ask you to manage, I don't just expect that you come and tell me that I'll give antiretrovirals. If it's over 8, you are going to get 2 over 8. If you're able to tell me the antiretrovirals, the common antiretrovirals we talked about recently, then you get 4 over 8. That's 50%. You've passed. But then that is not the end of the management. You need to go ahead and say you manage for opportunistic infections, which clearly the question I'll give you, there'll be opportunistic infections there. So you have to tell me that you give the patient Septrin. If you're able to put the dose, it's a plus. If you don't remember the dose, I won't deduct any marks. And then as part of the management, you should try and touch on the opportunistic infections there. So maybe the man has oral thrush, you should tell me that you give fluconazole. If you don't remember fluconazole, you can just say you give an antifungal medication for the oral thrush. If the man maybe has some herpes zoster shingles, which is called like varicella zoster, you should tell me you're going to give an antiviral medication like the cycle as part of your medication. If you are able to single out the clinical features, the problems the man has, and you manage that as well, in addition to giving your ARVs and your Septrin, you get 8 over 8. You see, it's fair, right?
Yes,
so that it will be fair. It will be fair for the person who would go the extra mile to write the Septrin and manage the opportunistic infection. And then it would also be fair for the person who only writes ARVs, and it will only be fair for the person who go ahead to write tenofovir lamivudine-dolutegravir. If you have a question on HIV/AIDS, that's how I expect that you go about it to answer. Okay, so you should be fine for your internal medicine 2 exam. 3 questions, 100 MCQs. That one is a standard. I would have given you 50, but the school would disagree. So 100 MCQs, 3 questions. Yes, hi.
Sir, please, when are we writing the internal medicine?
So you are going to discuss as a class. I proposed 30th and the 31st, but you are going to discuss as a class and you get back to me.
Oh, okay.
So
That
so
means
meaning
you have
the
like 10 days from now.
So that means that we had is cancelled.
It's cancelled. Yes, please.
So, same for the emergency medicine.
The emergency medicine is going to be exactly a week after your internal medicine, but that will be like close to a weekend. So that will be on a Thursday or on a Friday.
Oh, okay.
So please, can you slow down so that we see?
No, wait. I said the emergency medicine is going to be 2 weeks.
2 weeks.
Let's see. Oh no, I mean it will be a week. Initially it was going to be 2 weeks so that you have a supplementary in between. But now you are going to have a supplementary and then the internal medicine 2 in the same week. So the emergency medicine will be a week after the supplementary. Okay. Yes. For now, the proposed date for the emergency medicine is the 10th. If anything will change, we'll be looking at probably 9th. As for now, the proposed dates for emergency medicine is 10th. Proposed dates for supplementary is 3rd. So you kindly inform all those who would have to raise it and those who when we'll be writing. Okay. All right. So I think we've done enough today. Nick and Thomas will prompt me what time will be better for us tomorrow to have the session. And then
So please, I saw some question that was, please, can I see it?
Which one, please?
From this one, this emergency medicine.
Emergency medicine.
Like this is that this one, this is one, the one. Yes, please.
The one we just went through. Well, the
Yes,
MCQs.
Yes.
What question was that? What number was that?
They are only MCQs.
You mean what we just discussed?
Yes.
Uh-huh. You said what? You saw a question there.
Yeah, the last part. I want to see something there.
You want to see something? You like seeing things, don't you?
Your eye will.
Which one? This is the last part.
Oh, sit down. Sit down after this one.
Oh, which one?
This one, yay. Yes, say.
Okay. Don't worry, that question. That's number 1 there is not. And you said diabetes. Oh no, it's not. But you see, that I've already discussed that question with you guys in class before. So if you were in class for the stroke lecture. Oh no, we've already discussed it. They say radio talks but once in the previous times. We discussed this topic before we had our stroke lecture, if you remember. So those in class for the stroke lecture would remember I projected a Word document and then we went through. So you can go back to the recording you did for the stroke lecture. It's there, okay? It's the same thing, it's there. So you just go back and then Yes, hi.
Please, when is our next lecture? This is the last one.
We are done for internal medicine. If there's time, and you guys are arranged, we can just meet and discuss the leukemias, which I've sent you the slides. We can equally do that after your emergency medicine exams as well. That can be a goodbye lecture, because I'm not going to bring that in your section B. I'm not sure maybe it would appear in your section A, but it won't be more than 2 or 3 questions.
And we know you, the moment you lecture on it, it will come.
So we can have that lecture after your emergency medicine exam. I mean, just to help you in your practice, really. Just to help you. But for emergency medicine, it's just a revision that we are about to do, and then a presentation that I expect from you next weekend, regular and weekend, on shock and poisoning. Okay, but apart from that, we are just going to have a revision of the topics that I just projected from tomorrow to next week. Then we are done. Okay.
All right.
All right. Are you excited about the exam? You should be excited. It's easy.
It's easy.
All right. So other people who have issues too, I mean, some people have contacted me pertaining to their exam. So if you still have issues, you can contact me. If you want to know where you fell short, you can contact me, and then I'll take you through what you wrote and then what you should have written. Okay. Yeah, but apart from that, I think we are good to go. If we go through your paper and there's a mistake, of course, we'll always correct it. I've submitted your marks already though, but I can always call Mr. Party and Dr. Osei to fix the change. It's not a problem. But I can assure you there was no mistake. If anything, if there's anything, almost everybody here owes me about 7 to 10 marks. If there's anything, everybody owes me about 7 to 10 marks. Don't worry, I won't take that out of your subsequent exams. I dashed it out freely to you. So if you would rather want a remark and then HOD and everything is going to supervise, you rather get lesser marks, you see. You get like less than 7 marks. Trust me.
Trust me. So. HOD.
Because once there's a remark, I'll have to present your papers to them afterwards. If you want a remark, you have to apply through the school. So you apply through the school, I'll mark it for you, and then you get the same mark minus the 7 that was added. Or for some people, they got 10. They got 10 because their marks were so low that the 7, they would have still gotten less than 40. Anybody who is rewriting actually got 10 additional marks free, but still didn't make 40.
Hey.
Okay. All right.
So section B and section A.
Yeah, section B and section A, as in.
Hey. I mean, those who are rewriting.
Oh, you are writing everything.
Okay.
So you said you gave them 10 marks, so they couldn't.
So you are writing everything. You are writing both section A and section B. The marks was such that. Excuse me, I'll be down a bit. So your 100 MCQs was split to 50%, right? And then your written was also basically split to 50%. And then it was converted. And then afterwards, as I said, you did presentations and whatnot. So that also came into the picture. Without that, there would have been a lot of 50s. But with that, there were a lot of 60s and some 70s. A person who had a very high mark. Some people were very impressive during the exam. So I'll call them as well. Yes, Lorena, you had a question. Oh yeah, okay. Okay, I think we are okay. Evans, your hand has been up since we started. You still have your question?
Oh, sir, I've already answered.
Yeah, good. All right. Okay, great.
Put your hand up.
Okay.
Put your hand.
Yeah, sir, I have a question.
Yeah. Okay. Yeah. Let your question come, please.
Yeah, sir, when we say management, example, you are giving the clinical study, a case study, and you have to write the management for it. In the case study, in the questions, they didn't ask you of any investigation. So it's your impression and then probably one or two questions together with your management. The management, is it compulsory that you add your investigation to it?
Okay, so I don't mark investigations in management. If you check most of the case studies I give you, I most of the time will ask you for your investigations before management. So I don't give extra marks for management, for investigations. However, if you get a question and then there's no investigations as part of it and your management, you tell me, oh, you do this before you go ahead to treat, then maybe you might get an extra mark. But most of the case studies I give, there's always investigation before management. So you don't need to rewrite. And thanks a lot for reminding me. I wanted to say this. So if you have a question, not just for my exam, but for every exam, if you are answering management, question on management, okay, there's a strategy to go about it so that it will be easy for who is marking and it would also be easy for you and you end up saving a lot of ink. Okay, if I ask that, okay, I give you a case of maybe a CVA. BP 11076, temperature 39.9 degrees Celsius, pulse rate about 96 beats per minute, respiratory rate about 18 cycles per minute, and then SpO2 was about 93%. So if you have a case study like this, okay, I've given you the case study. The first question was, what is the likely diagnosis? Okay, and then the next one was list 2 differential diagnoses, right? Which was 4 marks. Then list 2 signs you will look out for during the examination of this patient, which is also 4 marks. And always you realize that mine D, even if I should scroll this up a bit, you can see that the question before this, mine D, was list 4 investigations you perform in the management of this patient. And that's the same thing in 5. List 4 investigations you perform for this patient. Because the investigations are very key. I always give you the case study, just like a real life situation that you've seen, and you need to do labs for the patient to help make your diagnosis after you've thought of differential diagnosis. It is like a real life case, and then you come to your management. So I don't expect that in your management, you tell me you do this investigation. No, you go straight to the point, right? So in the management of this case, clearly you need to admit, okay? So you don't have to, in your management, you don't have to write in the, what's it called? This is a first person tense, or you don't have to say, I will admit patient. I will set I'll set lines and I will give crystalloid. I would know, because most people were doing that. Okay. When this is like higher level of education. So when you go and write your exams with MDC, don't be happy to see that. They'll think we haven't taught you how to answer questions. So in managing, you make it easy by saying 1, if the first thing you need to do is admit, so you write 1, admit. 2, then you state what you want to do. Okay, set line and start intravenous fluid infusion. Then you can put dash there and write what you want to give. Maybe 2 liters of normal saline, this, you write. 3, administer antipyretic dash. IVP more. If you know the dose, you put it there, blah, 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 blah. You get it. If you don't write administer antibiotic, you can just write administer IVP more 1 gram, blah, 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 blah. But sometimes you are happy to know that you know why you are giving the IVP more. If you say administer antibiotic, we know that you want to control the temperature. It's 39.9. The patient is uncomfortable, so you want to administer antibiotic. Then you put your dash and you put your maybe IVP more there. For administer antibiotics, if it's a clear cut, a condition that we all know that this condition, you need to give this antibiotic, then you write it. For this case study, it looks like meningitis. And we know in the management of meningitis, we give ceftriaxone. If we want to give brand Rocephin. So if you say administer antibiotic, you can put dash IV Rocephin. If you know the dose, you put there 2 grams daily for 7 days, something. Okay, if you don't know, you can just say administer empiric antibiotics after you've taken sample for culture and sensitivity. You get it. And then await culture and sensitivity results, and then switch empiric antibiotic to antibiotic according to culture and sensitivity results. That's how you answer. So if you number it or you put dash, 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 it's easy for whoever is marking. You get it.
Yes, sir. Yeah, okay.
Yes. You'll be fine. For instance, look at this question 3, for instance. Look at this question 3. So your seniors got this question recently.
Yes,
a 20-year-old student presented to the ER around 11 p.m. with history of cough, episodic breathlessness, and wheeze. He has had 2 previous episodes of the above in the last 6 months. So if you look at the history, cough, wheeze, episodic breathlessness, look at the time the patient is presenting to the ER, 11 p.m. The history further goes on to tell you he has had this in the last 6 months. So it means it's not the first time the patient is having these symptoms. Complaints of chest tightness, feverishness, and runny nose. He usually walks his dog at late hours. So you see, all these things point to certain things. It's not just there for fun. He doesn't smoke cigarettes or he doesn't do shisha as well. And they're giving you vitals nicely over here. You're reducing SpO2 and increasing respiratory rate and pulse rate. So with this history, the question will be, what is your most likely diagnosis? And then differential diagnosis. And when you examine the patient, what will you find? So with this history, someone should make me happy and tell me what will be the first thing they are thinking. If you are asleep, you've gone for your night shift.
Okay, so
you are trying to sleep small, and then this case asthma. Good. Asthma. So this is excellent. So this is one question they got. Most people did justice to it though. So asthma, I'll give you 2 marks. If you write bronchial asthma, I'll give you 2 marks, but I'll be more happy if you write bronchial asthma. Okay, because sometimes there's something we call cardiac asthma, but this time I was very lenient. So those who are completed, they also got a similar question. Those who wrote asthma got 1. Those who wrote bronchial asthma got 2. But then this time I said, okay, let me be nice. So those who wrote asthma and bronchial asthma all got 2. Okay, so it's 2. So what will be your differential diagnosis? In this current time, if it's not asthma, what can it be?
COVID-19.
Pneumonia or what?
Pneumonia.
COVID. Exactly. COVID-19. So ideally, if you are going for some high-level exam and you go and say TB, they'll look at you somewhere and you might not get a mark. You might not get a mark because if it's a TB, but I mean, this time people who wrote TB, I still gave them the marks. People who wrote bronchiectasis, I gave them the marks. But if it's TB, the history would be different, right? We'll be telling you about weight loss, night sweat, hemoptysis. That is what we'll give you. Okay. 2 clinical features to look out for during the exam. What would you look out for?
So we're looking at
If you are not sure, If this patient comes to you and you're not sure, what's the first thing you do with your stethoscope? I've made it easier for you.
You listen to the chest.
To listen to the chest, and what will tell you this is asthma?
Preps.
Bronchi. Yes, someone said bronchi. So you hear bronchi. So usually when I used to do locums and whatnot, now I've stopped. On a night shift where you are so tired because you've gone to work somewhere else, your actual place from morning to 6 p.m. and you are going to do some locum at 8 p.m. till morning. And then 12, now you are trying to put your head on the table, they'll come. They'll come and call you, Dr. Vinta, and you are angry, but you have to be nice because it's private. Because it's private practice. So
why are you angry? Why are you angry? Why are you angry?
So as you go,
you want extra money, so
and the situation calls for it. You are pissed as soon as you get there, and then sometimes the worst thing is you get there and it's a patient who you've seen before and you become friends and has been even WhatsApping you and things. Doc, what medication should I take and what's not? So you get there and you can't even be angry. You have to, then you're like, and then, sometimes the nurses will be so angry because you see, before a patient gets an attack, they've been having some small triggers during the day or even the previous day and whatnot, and they've been using the inhaler. Instead of them coming during the day, they won't come. And then at night when the weather gets cold, that one, they're afraid that if they sleep, don't wake up again. So they'll quickly come. And, you're angry, but when you get there, the patient is also dying, so you don't have to be angry. So usually for me, when I get there, the first thing I do, because you are not going to be taking the history, this is emergency medicine. You want to know what it is. Now, you're not sure if this patient has an acute LVF, because most of the time, the nurses will communicate the vitals to you before you go. And usually in asthma, if it's getting bad, the BPs will go up, right? And it's a form of compensation. BPs will go up, pulse will go up. So you rush there, and if you don't listen, you just say, "We'll give this antihypertensive." And if you make a mistake and you go and give like a beta blocker, which is non-selective, you kill the patient. So usually when you get there, the first thing, you have your vitals there. Patient is breathless. It can be an acute LVF. It can be some pneumonia with pleural effusion. It can be some pulmonary edema. But it can also be something simple as asthma. So you put your stethoscope there, and then the first thing you hear is the whistling sound or the rhonchi. Then you know, this is asthma. Then you say, okay, nebulize. By then, nurses have started giving oxygen already. So nebulize, blah, 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 blah. And you go on. So that is so in terms of features, that is what you should be looking out for, rhonchi. And then you should also be looking out for something like the tachypnea, the tachycardia, the flaring of the iliac nasi, the intercostal recession, because they are all signs of respiratory distress. In very severe cases, especially when the patient has had the asthma for a very long time, and they get to you and you listen, you won't hear anything. You won't hear a rhonchi. Exactly. And that is what we call silent chest. And if you've forgotten that in severe asthma, you can get a silent chest, you say, oh, there's no rhonchi, so this is not asthma. Let's control the BP. You end up killing the patient. So if you go and listen to a chest and you don't hear any sound at all, if you are lucky and you have relatives, you ask, is the patient asthmatic? They go like, yes. Oh, this is a silent chest. Because you don't hear anything, you don't even hear vesicular breath sound, you hear nothing. And then you say, this is a silent chest. Then you manage and you quickly make arrangements, you ambulance, then you refer. Okay.
Your microphone.
So, pardon? Okay, so basically that, and outline your management. So this patient, the management was 8 full marks. You should be able to tell me about oxygen, nebulized salbutamol, ipratropium, IV hydrocortisone. I taught you this in medicine 1, but we'll go through. If it fails, you should be able to tell me about aminophylline. Afterwards, you should be able to tell me that because of the how do you call it? The runny nose and whatnot. Possibly there's some form of infection. So you want to give some antibiotics. If it's a bacterial infection, you'll take care of it. If it's a viral infection, your antibiotics will prevent a secondary bacterial infection. You have to write all this before you can get your 8 marks. And on top of that, you tell me that you are going to discharge your patient on maybe a salbutamol inhaler or a beta-2 agonist, and then a steroid combined inhaler like Seretide or Symbicort. You can get all the 8 marks.
Doc,
So,
please, can empyema be a differential?
yeah, well, empyema can be a differential, but then the thing is that empyema itself won't just appear. It will be a complication of something else.
Okay.
But then people wrote empyema and I still marked them correct though. But if you write pneumonia and you write empyema, if I'm in a good mood, I'll give you all the 4 marks. But if I'm in a bad mood, I'll give you 2.5 or 3. Because the empyema, there is a complication of the pneumonia. You see.
Okay.
Yeah. So I expect that you list your management. Like that's why we are saying outline. So maybe if you just state, you write the first step, you write the second, you write the third, it's easier. But if you put everything together in one block or paragraph, especially the handwriting, my handwriting is not so nice. So my way of beating examiners is that I'll write and leave space, right? So that they can see what I'm writing clearly. But if your handwriting is just like my own and you write together paragraph, you might be making some sense. But then some examiners, they don't waste time. They'll give you an average mark. Don't give you below average. They'll give you an average mark. Meanwhile, the point you are making is above average. Okay, so try and then list and space in your exam so that we know what you are writing. All right. Okay, I think we've done enough. Tomorrow we'll have a discussion. We'll just revise, look at the management of the first 4 topics, and then we can go on and on. If you have any questions, later, you can always send me a WhatsApp message. I'll address your questions. Enjoy your evening.
Okay, good night.
Thank you very much.
All right, okay, sure.
Bye.
Good night.
Bye.
All right.